Antihistamines for the treatment of allergies. Often considered the epidemic of the 21st century, allergies have caused physicians to explore options in allergy control, treatment, and possible cures. The earliest known report of an allergic reaction was that of King Menses of Egypt, who died after a wasp sting between 3640 and 3300 BC. So what are allergies and what is responsible for allergies? Allergies are caused by a hypersensitivity reaction of the antibody class immunoglobulin E, also known as IgE, located on the mast cells in the tissues and basophils in the blood. After being exposed to an allergen and inhaling an allergen many times with no trouble, the body would soon flag it as an invader. During this particular exposure, the immune system studies the allergen and readies itself for the next exposure by developing antibodies, specifically IgEs. During the next exposure, the immune system kicks into action and the antibodies recognize the allergen. After recognition, the activation of mast cells is triggered. These cells are responsible for allergy symptoms in the lungs, skin, and lining of the nose and intestinal tract. The mast cells burst, releasing chemicals such as histamines. The chemicals then cause allergy symptoms including swelling and runny noses. When histamines are released, it causes inflammation by increasing capillary permeability, causing smooth muscle contraction, mucus secretion, and parasympathetic nerve stimulation. Allergic rhinitis, often called hay fever, is closely related to symptoms that affect the nose, as symptoms occur when people breathe in things they might be allergic to, such as dust, animal dander, or pollen. Symptoms of allergic rhinitis include runny or itchy nose, sneezing, watery eyes, coughing, headache, fatigue, sore throat, and more. Antihistamines are drugs that oppose the activity of histamine receptors in the body. Histamines are released by your body during an allergic reaction and acts on a specific histamine receptor. The largest class of antihistamines is H1 antihistamines. Antihistamines that target the H1 receptor are used to treat allergy symptoms in the nose, including itching, runny noses, and sneezing, as well as insomnia. Antihistamines are also known to be inverse agonists, where they compete with the histamines for binding sites at the receptors. Antihistamines cannot remove the histamine if it is already bound. Who is most at risk? Allergies can develop at any age, but they commonly occur in children. Allergic conditions also tend to cluster within families, as one's risk of developing allergies is related to his or her parent's history. If neither parent is allergic, one's chance of having allergies is 15%. If one parent has allergies, the risk increases to 30%. And if both parents have allergies, the risk increases to greater than 60%. One's environment can also highly predict the allergies that one develops, as constant exposure to an allergen can cause the symptoms to appear earlier in one's life. Allergies are one of the most common health conditions affecting every 1 in 5 Americans for a total of 50 million Americans. In 2011, allergies alone accounted for more than 17 million physician office visits, 30,000 emergency room visits, and several hundred deaths in America. Allergic rhinitis can be seasonal or perennial and affects between 10% and 30% of the world's population. In 2012, 7.5% or 17.6 million adults were diagnosed with hay fever in the past 2 months, and 9.0% or 6.6 million children reported hay fever in the past 12 months. In 2010, 11.1 million visits to physician offices resulted with a primary diagnosis of allergic rhinitis. So what is the cost to treat allergic rhinitis? In the year 2000, over $6.0 billion US was spent on prescription medications to treat allergic rhinitis.
The histamine H1 receptor is a GPCR with the classical 7-transmembrane domain structure and is involved in inflammation and allergic reactions. It's expressed in the endothelial cells that form blood vessels, in smooth muscle, and in the central nervous system, including the brain. Within the body, the histamine receptor is activated by the small endogenous ligand histamine. H1R activation affects inflammation through the phospholipase C signaling pathway, which activates the transcription factor NF-kappa B and leads to increased production of pro-inflammatory cytokines. Outside of the cell, these cytokines cause swelling and lead to leaky capillaries, which account for the traditional symptoms seen in an allergic response. Inhibition of the H1 receptor, then, can decrease this cytokine production and reduce the inflammation. Interestingly, the H1 receptor exhibits constitutive activity. In other words, the receptor has some amount of basal activity even in the absence of an agonist. In this schematic, histamine acts as an agonist to increase activity, while an antihistamine drug functions as an inverse agonist, meaning that it suppresses activity of the H1 receptor below the baseline levels typically observed.
The actual development of antihistamines began nearly 80 years ago in the lab of Daniel Bovet and Ernest Renou at the Pasteur Institute in Paris. Bovet was originally looking at two groups of substances that are called sympatholytics and parasympatholytics, and their role in minimalizing the effects of adrenaline and acetylcholine. Bovet recognized that histamines are toxic except when introduced through absorption in the intestine, and because of this, he hypothesized that histamines exits in the body normally when in combination with the neutralizing agent. Furthermore, he stated that only the free histamines are the ones that produce allergic symptoms. This research led to the discovery of the first H1 antihistamine in 1937, called piperoxine, through phenotype-based discovery. Piperoxine was the first step towards the proliferation of the class of H1 antihistamines. However, the drug was too toxic in humans. But in disease model guinea pigs, the drug was able to protect the animals from bronchial spasms induced by histamines. After 5 years, M.M. Monnier synthesized the compound antigen, which served as the first antihistamine to be used in therapy. Diphenhydramine followed suit in 1945, which is the popular medicine Benadryl. Chlorpheniramine and brompheniramine were both introduced before the end of the decade. There are a number of structural features that are consistent in each first-generation antihistamine drug. Each compound consisted of two aromatic rings and an ethylamine with small alkyl groups. Also, steps were taken to increase potency of the drug. For example, binding to the receptor is most effective when the aromatic rings are not planar. These are the very first-generation antihistamine drugs: Antigan, diphenhydramine, chlorpheniramine, and brompheniramine. As you can see, each of the first-generation antihistamine drugs contain an ethylamine and two aromatic rings. Although these drugs serve the primary function in blocking the effects of histamines, there are several downsides to the first-generation drugs. First-generation H1 antihistamines have the ability to cross the blood-brain barrier and in turn interfered with normal histaminergic transmission. Normal stimulation of H1 receptors leads to the arousal and the sleep-wake cycle, reinforced learning and memory, as well as controlling body temperature. The release of histamines during the day leads to arousal, while at night leads to passive reduction of this response, which is evident when we think about normal human functioning. The first-generation drugs led to daytime sleepiness, drowsiness, and also problems with concentration and memory. However, because of this side effect, we see that drugs like diphenhydramine are used in sleep aids. As we will discover later in this presentation, the second-generation antihistamines control for these side effects. First-generation H1 antihistamines come from the same chemical backbone as tranquilizers, antipsychotics, and antihypertensive drugs. Because of this, they have poor receptor selectivity and sometimes interact with certain biological active amines, which lead to antimuscarinic and antiserotonin effects. There are 5 different classes of first-generation antihistamines: alkylamines, ethanolamines, ethylene diamines, piperazines, and tricyclics. Alkylamines lack the usual central molecule, which links to 2 aromatic rings, and at least one of the rings contains a nitrogen. Examples of alkylamines are phenyramine and tripolidine hydrochloride. Ethanolamines, such as diphenhydramine, have anticholinergic side effects. However, they have reduced gastrointestinal effects and compared to the other classes. Ethylene diamines were the first group of clinically effective antihistamine drugs. Piperazines are related to ethyl diamines and ethanolamines and also have anticholinergic effects. Finally, tricyclics are similar to tricyclic antidepressants, which lead to their chologenic side effects. Pharmaceutical companies are constantly looking for ways to increase the efficacy of a drug, and there are two factors specifically that determine the efficacy of H1 antihistamines: the affinity of the drug for the receptor and the concentration of the drug at the H1 receptor. Affinity is determined in vitro preclinical studies, and the Ki of the drug is calculated as the concentration at the receptor, with lower Ki indicating higher potency. Volume of distribution is usually another method in which the concentration of a drug at the receptor can be calculated.
Second-generation antihistamines arose as a result of an effort in the 70s and 80s to produce better antihistamines that minimize the adverse side effects of the first generation by preventing the crossing of the blood-brain barrier and increasing specificity for the H1 receptor. Cetirizine, marketed as Zyrtec, is a good example of a second-generation antihistamine. We can see the conservation of the same pharmacophore present in the first-generation antihistamines, but the addition of a carboxyl group to the drug decreases its lipophilicity. Furthermore, at physiological pHs, the drug is predominantly in its zwitterionic form. The charges on the molecule prevent the drug from readily crossing the blood-brain barrier, and thereby almost eliminate the drowsy side effect at low dosages. In addition to preventing the drug from crossing the blood-brain barrier, the zwitterionic characteristic of cetirizine also grants the drug greater specificity of H1 receptor over other GPCRs, including many in the central nervous system. The negatively charged carboxyl group interacts with the positively charged lysine residue in an anionic binding pocket of the receptor. Importantly, this residue in particular is specific to the H1 receptor and contributes to the selectivity of second-generation antihistamines. This carboxyl moiety is present in a number of second-generation antihistamines and is an effective mechanism to preventing drug crossing of the blood-brain barrier and increasing selectivity for the H1 receptor. Let's take a look at the structure of several other second-generation antihistamines. Acrivastin, terfenadine, loratadine, ketotifen. The structures of these drugs are varied, but generally they are larger than first-generation antihistamines. It is hard to specify the exact structural components that distinguish them as second-generation, but in the body these drugs do not readily cross the blood-brain barrier. Second-generation antihistamines showed great improvements in alleviating the drowsiness associated with the first generation, but often they still retain the risk of cardiotoxicity. This side effect, while rare, could lead to patient death. Terfenadine was one such second-generation antihistamine that became known for its cardiotoxic effect. Terfenadine was a prodrug that was completely metabolized by the liver enzyme cytochrome P450-3A4 to its active form, fexofenadine. Terfenadine is normally not measurable in the plasma due to its quick metabolism, but drug interactions leading to the inhibition of the CYP3A4 enzyme leads to a buildup of the cardiotoxic drug. In large plasma concentrations, terfenadine causes inhibition of the hERG potassium channel, an abnormal heart rhythm. Due to its cardiotoxic effects, terfenadine will be removed from the market and replaced by a formulation of its active metabolite, fexofenadine. Administration of just the active metabolite retained the desired inhibition of the H1 receptor while removing the cardiotoxic effects of terfenadine. Several such instances of active metabolites replacing existing first or second generation drugs to alleviate cardiotoxic effects has led to the creation of the third generation title. There is controversy over the use of this term because there is often not a drastic improvement in the PK profile of these drugs, and in many places, these drugs will still be referred to as second generation antihistamines. Looking at the PK profiles of different antihistamines of all three generations, we can see similar trends. All have similar values for Tmax, time to action, half-life, and area under curve, indicating similar absorption and clearance within the drug class. Notably, there is no trend in increasing binding affinity to the H1 receptor, shown as a Ki value, seen throughout the generations of antihistamines. This is consistent with the equivalent efficacy shown by all generations against allergic rhinitis, with significant differences only in the side effect profiles of the drugs. Examining the drug class as a whole, the ADME properties can be summed up. All antihistamines are lipophilic and are readily absorbed when taken orally. Antihistamines show a large variety for volume and distribution values, but as a whole, they bind to plasma proteins at levels of 70% or higher, and through the blood, target H1 receptors are easily accessible. Almost all antihistamines are metabolized to some degree by liver enzymes. And finally, antihistamines are excreted in urine, while some exceptions can be found excreted in feces.
So why should allergic rhinitis be studied? Although allergic rhinitis is not associated with severe morbidity or mortality, allergic rhinitis has a major effect on the quality of life of the more than 50 million Americans with this disease. Over the course of their development and improvement, antihistamines have proven very useful in treating allergic rhinitis in affected populations.